I've been asked to reflect a bit about the global impact of COVID and thinking about the equity issues that have come from this. And I think the first thing to say is simply that this isn't new. We always know that health emergencies and major outbreaks and epidemics expose the fault lines across our society. And these fault lines are multiple. They can be intergenerational, they can be racial, they can be socioeconomic, they can be gendered. And what happens is you have these major shock events and it exposes what's already there in our society. It exposes who's able to get access to healthcare, who's able to afford to take time off work to be sick or to care for loved ones. It exposes the biases that our policies that are created to protect people actually might promote or compound depending on how they're written. And this doesn't just happen at the national level, it happens at the global level. And we're seeing inequities between countries. And I know we're going to come on to talk about the vaccine distribution later on today, but we see inequities around who's being able to access vaccines. But then once we have vaccines in countries, distribution of those vaccines again exposes a number of inequalities. And these really need to be taken seriously by policymakers. We know that policymakers are, under a lot of stress and strain, but they have to recognize that the policies they introduce create certain policy path dependencies. They prioritize certain groups over others. And we need to make policymakers, and I would encourage everyone to think about how can we get policymakers to think about these issues in other ways? How can we ensure that the most marginalized in our societies, the ones who are most at risk of contracting COVID, the ones who are most at risk of losing their job because of COVID, are not the ones who are left to the end when it comes to vaccine distribution. We have to try and think about ways of building back better. And without sounding like a tagline, this really is an opportunity with all the horrible that comes with COVID. I see this as a really meaningful time for change in the way we think about health policy. And I think this should be at the center of how we go forward. Particularly as a social science institution and thinking about the social sciences of this, we know that in the history of infectious disease control, the way that the WHO creates policy and the international health regulations around it, the way governments respond to epidemics like this, we have this tension between public health and the economy. And this has been these two issues have been in tension for many years. But what COVID has shown is that this is a false dichotomy. We have to have public health first. We have to have healthy populations to be able to generate healthy economies. And I think as we come on to think about these inequities, we also need to take public health more centrally into the way we think about economics and the way we think about economic development, and make sure we can mainstream financing for health systems, financing for health policy interventions, and ensuring the best care to everybody across the world. Now, I'm excited this evening to be able to host two amazing speakers who are going to tell us about intergenerational equity in Colombia, focusing on issues of vaccines, lockdown, and high-cost health treatments. So first of all, I'm going to introduce Zulma Kukunuba, who's an assistant professor of epidemiology at Pontificia Universidad Javeriana in Colombia, and the MRC Rutherford Fund Research Fellow at Imperial College London. She researches using statistical and mathematical models to understand the determinants of the spread of infectious diseases and the impact of control strategies, particularly in Latin America. Now, I think as with most people working in health at the moment, she's been heavily focused on COVID this year, but previously she's got a rich history of working on a range of vector-borne diseases, including Chagas, Zika, chikungunya, and malaria. So I'm hoping you might be able to talk about, what you've learned from that and how we can compare the response to COVID to that of these vector-borne diseases. Following Zulma, we will have Andres Vecino present, and he's an assistant scientist at the Johns Hopkins Bloomberg School of Public Health. He is a health economist who works on the economics of prevention and intersectoral factors affecting health systems. And he's also on the board of directors of the largest Society of Health Systems Researchers, Health Systems Global. So without further ado, I shall pass over to Zulma.
Thank you very much, Claire. And it's a pleasure to be here with the LSESU Colombian Society. And so I was asked by the Colombian Society to talk about some epidemiological perspectives of vaccinations, lockdowns, and intergenerational equity. So the first thing that I wonder was what intergenerational equity actually means. And so I found a definition about it refers to fairness between generations currently living and generations yet to be born. So the first thing I thought is COVID pandemic itself is really inherently intergenerationally unequal. And that comes from the fact that age, by far, age is the main risk factor to death, to die from COVID-19. And that differs very much from previous pandemics, for example, 1918 pandemic and 1957 pandemic, where it was the trend in terms of illness and death related to age was the opposite. So I think to begin with this idea of inequity and intergenerationally, it marked from the very beginning the way we perceive the pandemic and the way we respond to the pandemic. And if we look at the Colombian data, for example, which by March 1st is about 60,000 total deaths, about 70% of this have been in people at the age of between 60 and 90. However, that inequality, which is by nature and unfortunately at the individual level, also propagates at the population level. So we will see that low-income countries will be natural having lower fatality rate due to distribution of age that is biased toward younger populations. Although in high-income countries would be the opposite. So we will expect to see much higher fatality rates in countries such as the UK or other high-income countries. However, the fact that the control of the pandemic depends on how many contacts we have per day and how many of them will be risky contacts, indicates as well that the probability of acquiring the infection will be very much related to how we are able to stop having physical contact with other people. And when it comes to that, it seems that high-income countries are much more likely to be able to reduce the number of contacts they have per day. And for example, in one study that we published recently from the team at Imperial College has shown that in order to suppress viral transmission at the population level, we may need in high-income countries a reduction in average of reduction in mobility in average of 50%. But when it comes to countries such as Colombia and other Latin American countries, we need to reduce transmission by approximately 80% in average in order to reduce, to suppress the virus. So it was very evident from the very beginning that this pandemic was really unequal in the way we could respond to control. And we saw, for example, in the first studies we did in Bogota. Bogota is divided in the north of the city, live people of higher incomes, and in the south of the city will be living people of lower incomes. And what we saw at the very beginning is that the ability to stay at home was much larger in high income parts of the city. So that marked from the very, very beginning of the pandemic a trend that still persists today, which is the disease is much more able to propagate across populations, the poorest populations in every single city. And so when it comes to how we control the pandemic as well, we see that vaccinations, which are one of the main responses we expect to expand in the coming months, has been really delayed in South America in comparison to other regions of the world. Claire already mentioned that, but I would like to emphasize that before the 90s, in South America, we had a pretty good capacity to produce our own vaccines. They were based on very traditional techniques and processes, such as live viruses inactivated, but that capacity to produce vaccines was reduced after the era of globalization, and after we kind of in South America, in most of the countries, decided that the vaccines will be bought to big manufacturers in the developed world rather than producing it ourselves. So when it came to this pandemic, our ability to produce our own products to respond to the needs in terms of diagnosis, vaccinations, treatment, etc., was down to the possibility of accessing what high-income countries would be producing. And by now in South America, there is pretty much no single vaccine, apart from Cuba that has 3 vaccines in phase 3 trials right now. There weren't at the moment any other vaccines produced by South American countries. And so we depend very much on these big manufacturers, and that means that the ability to achieve high coverage, which is in Colombia is estimated or aimed at least to be to cover 35 million people of our population, is very much delayed. So at the moment, Colombia has been one of the latest countries in South America to start mass vaccination, and only started a couple of weeks ago on February 17th. And today, less than 1% of the Colombian population has been vaccinated. And although at the very beginning, all the vaccines that are considered at the top of their efficacy and the type of vaccines that high-income countries are accessing, such as Pfizer, BioNTech vaccines, or AstraZeneca or Moderna, all those vaccines in reality haven't been really delivered to South America. Only this week, the COVAX mechanism started delivering vaccines to South America, starting with Colombia. But the major players for controlling the pandemic in South America will be other manufacturers, such as those coming from China. For example, Sinovac will be providing the highest amount of vaccines for achieving probably during the coming 2 months about 2 million people vaccinated in Colombia. And in regards to vaccinations as well, what we are observing at the moment, although the process has been really slow in terms of the provisions of the vaccines, what we are seeing as well at the moment is how large cities with much larger infrastructure have been able to deliver the vaccines much quicker. And whereas other regions with less infrastructure will be really struggling to deliver the vaccines in the time that it will prevent us from having a third wave, probably. And so I would like to finalize mentioning four challenges, at least that I'm not quite sure are the main challenges, but at least 4 that I consider very important in the short terms, in terms of the relationship between the pandemic and the response the society is having. And first of all will be, of course, vaccinations. We depend very much on how COVAX mechanism and as well as other bilateral trades between the country and some of these manufacturers will be able to provide the number of vaccines we need for the country, which for achieving this goal of 70% of the population vaccinated, we estimate will be needed at least 60 million doses coming during this year. The second challenge that I think is really important to mention is that because of the measures taken for mitigation and the lockdowns as well, school closing has been really an issue in South America and particularly in Colombia. And we are completing almost a year of a school closing. And this is not only, as I mentioned, not only in Colombia, but most of South America is experiencing the same problem. And with all the consequences, this comes to inequalities as well for children, but also for families. And in the long term, the consequences we will be seeing from this situation. And also the country has aimed to return to school this year. At the moment, less than 2% of children are really attending in-person school. And the third issue I consider very important is as well in terms of gender inequalities. We have seen that, there is an estimate that about 77% of families in Colombia, especially in rural areas, will be monoparental families. And that means depending specifically from women. And that means that all the effects, not only from the job market, the increasing in unemployment, particularly for women, but also in terms of the consequences of a school closing as well on women's ability to work. That's one of the big problems we are experiencing. And finally, a last challenge I consider very, very important for the short term in terms of how we'll be responding to this pandemic will be the migration process we have experienced between Venezuela and Colombia in the last 4 or 5 years. And we currently have an estimated of 1.7 million Venezuelan migrants living in Colombia. And that became such a situation when in December it was announced that probably the vaccination plan will be excluding migrants from these coronavirus vaccines, because in Colombia the legal status is attached to the capacity to provide some health services. And so that fortunately ended relatively well when in February it was announced by the president that Colombia will grant legal status to Venezuelan migrants. So that means that they will be able to access these vaccines, but there is still many challenges in that regard, because these people not necessarily are part already of the databases and the health system. So that will be one of the very big issues for achieving good vaccination coverage in this population. So yeah, I would like to end that at this point, and willing to respond to any questions.
Thank you so much, Zulma. I'm going to suggest we move on to Andres, and we'll take questions at the end for both of you, if that's okay. So over to you, Andres.
Thank you, Claire, Santiago, Tatiana, and the LSE Colombian Society for the kind invitation to join this panel. I'm really glad to be here, in part because I have personal links to the LSE. My wife graduated from there, and I have to say that probably the most important conversation I had about my dissertation was actually at the exit of the library, right in front of the George, with a professor from the LSE and then a PhD student at the LSE. So I really, really have a lot of appreciation for the faculty and the students at the university. So I was asked to talk about challenges and opportunities for the Colombian health sector after the pandemic. And I was thinking that perhaps I could separate my talk about in two parts. The first one would be about what have we learned in the pandemic. We have learned a lot of things in the pandemic, but I have selected just 3 that I think are important to inform our way forward. And the second part would be about what is that way forward. I think there are a few things that need to be considered in the health system in Colombia, but I will just focus on 3. And at the end, I will just have a corollary about whether actually there are opportunities, because I think in a way we're always overestimating the opportunity we have around the pandemic to change things, but I will explain myself later. So about what we have learned, I think one important part has been the value of preparation. We were not prepared for the pandemic. A few groups in academia, a few groups like Zulma's group actually were prepared, but most of the academia, most of governments, most of multilateral agencies actually were not prepared to handle the pandemic. We knew a pandemic was coming, but we actually underestimated the capabilities we needed to overcome it. This was reflected on how actually we responded to the pandemic. There were a lot of indices, rankings about pandemic preparedness. A lot of work had been done, and a lot of that work actually had turned out not demonstrating actually that level of preparedness. So I think at a global level, and it has been a year since the pandemic, it's amazing that we have started administering vaccines. And the fact that we're doing that demonstrates that in the aspects that we were ready to implement, in the aspects that we were actually prepared, and that's the case of vaccines, there were previous technology to do vaccines with older technology. Those actually previous technology done to produce vaccines with new technology as well. We were really prepared to produce vaccines, and 1 year later we're actually applying them, and that demonstrates the value of preparedness. But at the same time, we failed on what we have always failed, and in those aspects that we actually were not prepared for, and that's international cooperation, international coordination. Claire mentioned it earlier. Countries and multilateral agencies failed at raising warnings earlier when the international health regulations in 2004-5 were updated right after the SARS pandemic, coronavirus as well. We agreed on strengthening capacity and improving collaboration. Those were key elements to handle a pandemic, but that never happened. And this demonstrates really the value of preparation, how preparing for the next pandemic and prepare our health systems for the day-to-day business as well, not only for the pandemic, would actually have a return in the long term. And that has also happened in Colombia. Colombia did well in what it could do well. So we saw that in the first 4 months, the country was able to actually double the number of functional ICU units, including respirators, personnel, beds, space, infusion bombs, all the technology you need in an ICU environment. And that actually shows the strength of the healthcare system in Colombia. We were able to increase in less than a year from 800 PCRs a day to more than 100,000 PCRs a day. Not only being done in the National Institute of Health, but also being done at private laboratories, also being done by departmental, sub-regional laboratories. And that actually shows that we had capabilities in advance that we were ready to scale up. Similarly happened with data. For those of you who work in Latin America, you know that it's really difficult to get data and day-to-day granular data on the pandemic. Zulma and myself in a couple of days will be publishing a paper on contact tracing, and actually the data we used for that paper was public data. And we cannot underestimate the value of real-time, day-to-day granular data. So civil society, the academia, and multilateral agencies can actually input on how to handle the pandemic. So those are the things we were good at the beginning, and we demonstrated we could do it better, and we could scale them up over time. But similar to what happened in the world, we failed on those key factors that we did not build in advance. And one of them I think is really, really important is primary care and public health. You've seen the effort of other Latin American countries. One example is Costa Rica, Uruguay. They have a very strong primary care systems and public health teams. Costa Rica was able to manage the pandemic pretty well and contain it basically until September. That saved a lot of lives. And Uruguay has been able to contain the disease until now. And that's a huge achievement. Of course, these are smaller countries, but this also reflects the good governance and the strength of the primary care health systems they had. When the pandemic was happening, I had the opportunity to talk with officials from both countries, and both were telling me that they use their primary care teams to, and they switch them towards, for example, contact tracing efforts. So that shows that their previous capacities were key in order to contain the pandemic earlier, and that's what both countries did. And we have identified this in a chapter we wrote with other colleagues at a book called Policy Analysis in Colombia, which is a series of books on policy analysis across countries. We did the chapter in health. One thing that was really important and a finding in this chapter was that was the divide that there was in policy analysis capabilities between the national sector and the local sector. While the national sector had a huge information systems, people really prepared, a strong institutionality, and they were really good at evidence-based decision-making. These institutions like the National Institute of Health, as an institution that also does technology assessment similar to NICE in the UK, we're really, really good at that, while at the local level, there was a very evident lack of capacity, lack of funding, and another issues that were related to this lack of capacities, things like political capture, or people working there that were actually didn't have the skills to deploy effectively public health teams and primary care at the local level. And this was done before the pandemic. We knew this was happening. When the pandemic came, it was clear that at the local level, many cities and municipalities were not able to have a clear strategy on how to, for example, do contact tracing or do a specific lockdowns or closures where it was more needed. And that, I think, reflects what we were lacking. And to my view, it also reflects what we have to change in the perhaps short or medium term in Colombia in terms of the health system. And another aspect that was important in this chapter we wrote was the inability of the national level, and this includes all national health institutions, not only Minister of Health, but also other institutions, including the superintendents, to have to actually do a strategic planning around what their medium and long-term goals were. All these institutions are constantly putting off fires and have no time for strategic planning. And they have some time at the beginning when they do the national plans for development at the beginning of the government. And then, and that's the only time when they do this type of assessment. Then they fight for 3 years on putting up fires and emergencies that come up all the time, and they really don't have the time to think in the medium and long term how to improve the health system. And I think that is something that is really important and is lacking in the governance of the health system in Colombia. And we have seen this actually in our sense, because there's also not only time for strategic planning, but also because this has been worsened by the fact that governments are heavily constrained by the controllers and the inspector general, and sometimes they focus more on the form than the substance. And that reduces also the appetite for risk public officials. And we have seen this in the pandemic, in the acquisitions of vaccines, where there were undeniable but comprehensible delays on the purchase of the vaccines, basically because the government had to find a way to legally purchase these vaccines under the emergency authorization and using actually channels under of purchase under the private law instead of the public law. And all those constraints made really, really difficult for the country to speed up and compete, unfortunately, with other countries on the race for vaccines. And what has lacking there? I think it lacked perhaps not evidence-based policy because the intention was there, but all the constraints around all these controlling bodies were really, really, really difficult, made really difficult to conduct the purchases at the end. Perhaps it's necessary to focus more on the larger impact, and I'm talking about these institutions specifically. Consider failure and peer review systems on how actually these institutions can internalize failure in their strategic planning, how we're going to handle this situation or this situation or this situation. This is widely done in military environments, for example, but it's rarely done in civil environments. And there's an issue around transparency and trust. And of course, many Colombians here will relate to that feeling, but we are seeing that taking place specifically during the pandemic. So that's one thing we have definitely learned. The other thing is we're way more tolerant to poor leadership than we thought. And this relates to what Claire was mentioning at the beginning. Most countries in the world have focused on carrying out interventions that are vertical in nature, have not been consulted, have minimal or no congressional control, and the rule everywhere has been blanket measures. Examples of these measures are lockdowns, different types of restrictions to mobility, school closures, as Sulma was mentioning. And soon we'll probably start seeing immunity passports. We are already seeing some sort of immunity passports, which are the PCR tests 72 hours before traveling. And to me, it has been a great surprise to see this is happening when compared to other high-profile health debates in Colombia and the world. And in Colombia, those who are Colombian here will relate, for example, to what happened to a sugar student beverages tax, or what has happened with the aerial spraying of coca crops. So I think these measures are understandable in the short term, but in the long term, we should not allow them to happen again and for longer than intended. And I think that this comes from this thought of we're way more tolerant to poor leadership than we thought, comes from the realization that decision makers and leaders are humans, and they display the same cognitive biases that all people experience. We have seen denialism. We have seen that at the national level. We have seen that at local levels. We have seen fatigue from decision makers. They're not willing to take important decisions because they just experienced fatigue 1 year after. Some of them have inability to interpret the evidence. We have seen a lot of heuristics, which is the suboptimal decision making in the decision making process based on the most available evidence instead of the best evidence, and failure to update priors. And on that, for example, we've seen the topic of school closures. At the beginning, we closed schools because children were thought to be more efficient vectors of the disease. 1 year after, we know that is not true, but we still don't open the schools. And we're putting at a huge strain children, all children, but especially lower income children, who are less likely to catch up in the medium and long term on their lack of education. So having said that, I want to finish this part saying, this first part saying that I think that public health practitioners might have not been completely faithful to some known facts from our discipline. One of them is that health is not only the absence of disease, and I mentioned education, but also work and income are important, and we've seen in October, 26% of unemployment in Colombia, and female unemployment. Health is driven by context, and this relates to what Claire was saying at the beginning, that we should pay more attention when we do these interventions, who are we affecting? And finally, I think we need to find a way to, and finally, implementation is key. And we have seen this from the lockdowns, where reduced infections, where lockdowns reduce infections, but at the same time became less effective over time. But we actually perhaps didn't care much about that. We just wanted to show that we were doing something instead of doing the right and the smart thing. So that will be on the first part, which is, and I'll speed up in the next 2 minutes. That's the first part around what have we learned. What is the path forward? I think there are 3 main things that are important in the path forward. First one is reduce fragmentation and strengthen primary care. This is a lesson that we have acquired from the pandemic. Stronger primary care systems might be able to reduce comorbidities that will end up being reflected in death, but also being adaptable to any pandemic, as it happened in Costa Rica, as it happened in Uruguay. In the end, if we would have a good primary care system that is able to stay vigilant of hypertension control, glycemic control for those with diabetes, and detect cancer earlier, we might be actually addressing 50% of all burden of disease in Colombia. Most of the burden, half of the burden of disease in Colombia comes from these factors, and we can actually address them if we strengthen primary care. Second, public health. Many of you know that the health system in Colombia has 2 parts. One is the one that everyone blames for the healthcare system, which is Law 100 and the 1993 reform, and everyone blames that. But there is another part that nobody talks about, and I think that's endogenous, which is actually local health departments. How local health departments are working, how local health departments are actually building and strengthening their capacity. We're not talking about them. That's a product of decentralization that happened also with the schools, that happened also with sanitation, for example. And we really need to pay attention to that part, because that will be key for the next pandemic and for other conditions as well. And third would be health financing. Health expenditures are going to increase in the entire continent, with no doubt, and that will be the case of Colombia. First, because of vaccines. Second, because of low cost. And third, because of delayed care for these conditions that we didn't treat it because we were in lockdowns, because we were in the pandemic. So health financing, health expenditures will increase, and we need to find ways to improve health financing. 2 quick options for that, and with this I close. One of them is health taxation. At least in the short term, health taxes, sugary sweetened beverages, taxes for tobacco, taxes for some foods can be a way to improve, to strengthen health financing in the country. And the second one would be reducing evasion and elusion in contributions. Most of people who contribute in Colombia contribute based on the minimum salary, and that's not the real salary. And we're lacking, the Minister of Finance says that they do that, but they actually don't do it at lower levels of wages. They don't match income with contributions. And a tax reform that is coming should actually aim at this, should aim at matching income with contributions for all levels of income. Because otherwise the enforcement will only be focused, as it is now, in higher income people, but not in the medium income and lower income, which of course are more people than a higher income. And finally, a corollary, these are the 2 parts. What have we learned? What's the path forward? And finally, this corollary about the idea of an opportunity in the pandemic. And if you follow this idea of the punctuated equilibrium theory that suggests that there are long periods of stability in policy change, and then they are punctuated by these large shifts in society and that are opportunities for policy change. That is okay, that's good, and probably that's what we should be aiming at. But I think that the issue with this idea of an opportunity for policy change now around the pandemic is threatened by the fact that everyone is thinking exactly the same, all sectors at the same time. Education, excuse me, health, the Minister of Finance, Minister of Commerce, everyone is thinking around how we're gonna take this pandemic as an opportunity. And that will create a lot of competition between policy choices. And that's why I think that if we're going to try to change things for health in a smart way, we need to be, we need to focus on what is actually key, what is feasible, what is critical, what is incremental, and not trying to aim for the sky and not getting nothing done in the short term, in the medium term. So with that, close, and thank you very much for your attention.
Thank you so much, Andres, and also Zuma for your comments. So we've got 2 sessions left in this panel. One is going to be a question to the audience, and then a Q&A. And actually, if people are okay with this, and Santiago, please tell me. If not, I think it might be useful to come to the question part first and actually ask the audience the next steps afterwards. Is that okay with everybody?
That would be okay.
Okay. So I guess I'm going to take my chair prerogative and pose a first question before opening up to the audience. And in fact, I have 2 questions for you. The first one is, I remember in 2019, I was in the Instituto Nacional de Salud in Bogotá, and actually I was in the Health Emergencies Office or unit, I can't remember what it exactly was called. And compared to, I mean, I've been in lots of those offices around the world and in Latin America, and I was really surprised at actually how efficient it came across. And I actually thought compared to regional counterparts, it was relatively well thought through, maybe as a consequence of the Zika epidemic, that they had kind of invested some money in sort of pandemic or preparedness and response. And I wonder whether you think that had partly to do with the relative success of Colombia compared to its counterparts in the early months. And then does that lead you more to think that actually, the initial response was there, but going to what you were saying before, Andres, the longer term strategy was missing. And that's where you saw the kind of, we can do this if it's short and small, but maybe we haven't got capacity for the longer term and the long haul of a real pandemic. And then the second question linked to this is, you say there's no strategic planning, but so what was the strategy? What are they working on? In England or in the UK, our strategy has always been save the NHS. And it comes across as if we don't actually mind if people die, if the NHS is protected. We don't mind if people get infected, as long as they're not taking up space. We see different priorities, zero COVID strategies in other parts of the world. I'm wondering what the kind of overarching Colombian strategy has been to managing this response, and has it changed over the course of the pandemic?
So should I start? Yeah, so I think the question about what the strategy was or is has been really blurry, has been really unclear from the beginning. I think in reality, in the hope that initial lockdowns will bring the epidemic under control, most of the Latin American countries were really willing to start very early actions in terms of lockdown, reducing mobility, closing every single closed space and any contact. And actually, some of the Latin American countries experienced the highest stringency index at the beginning of the pandemic. However, I think relatively soon, less than a month after these strategies started, it was very clear to Latin America that it wasn't really working in terms of more than 50% of their population were informal labor And that then at that point, I think in Colombia somehow, and I think it has been mentioned by the Ministry of Health in a few situations, they really took the path of mitigation rather than suppression, which is the kind of the two levels of these strategies, the options, suppression and mitigation. And I think for most of Latin America, suppression really didn't work, not because there wasn't the willing to do that at the very beginning, but because in order to sustain that, those very low levels of transmission, more capacities were needed in terms of testing primarily, and testing was really delayed. The capacities were really delayed by this problem of not having own possibilities of producing the materials and reagents and other things needed for scaling up the PCR techniques at the very beginning. And also because it wasn't sustainable for most of the population were really receiving any economic support, not even people in isolating from the infection and their contacts. So I think although it wasn't really explicit in that way, Colombia and the Ministry of Health, the minister specifically, kind of mentioned that Colombia will be following a mitigation strategy. And from that point, it wasn't really important to reduce number of infection, rather to increase the capacities in terms of ICU, medical equipments, etc. And that worked really well. In terms of ICU, for example, the country passed from about 5,000 beds to about 10,000 beds. So at the moment it is double, twice as much as before the pandemic. And that is kind of the only thing that has enabled the country to continue going on without the health system collapsing.
Andres.
Sure. No, I fully agree with Sulma that the strategy, it was pretty clear that the strategy became mitigation, and that implied having the health system available to cope with all the severe cases that were coming. But I also think that over time also came this idea, not only about mitigation, but also the sustainability of these efforts. And because of the structure of the country, I think the objectives between the national level and the local level started to diverge. While the local levels were more focused on maintaining the integrity of the health system and making sure that ICU beds were not fully occupied, the national government was concerned about unemployment, was concerned about getting the loans to sustain those who were under the lockdowns, etc., etc. And even though both of them had good intentions, I think they didn't really fully align on how they could work together. And I think this was actually worsened by political differences that existed between the national and the local governments. Some local governments wanting to show leadership, and they did. Actually, I think that at the beginning, the leadership from some local governments pushed the national government to take this strong and important and necessary decisions. But over time, this became a more superficial fight that was more aimed at getting votes than really actually getting the work done and working together. So I think that there was initial difference in objectives, in policy objectives, and then there was a difference in political objectives. On what you said about the INS, I think that the INS had experience with epidemics before, and you and Sulma have seen the work in Zika, chikungunya, and the country has done actually a great job at vaccinating individuals kids for other conditions like measles. They have done, I think the disease control aspect of the country works really well at the national level. When this goes to the regions, it's not as good, precisely because of this weakness of the local health departments. And at the same time, this was not only a health emergency. And I think that is the point. The INS did a great job and has done a great job with chikungunya and Zika because those were health emergencies. COVID is a social emergency, it's an economic emergency. And there is where actually we didn't see that articulation between the health objectives and other objectives in the country.
Thank you. That's a really interesting point. I've actually never heard anyone talk about COVID as a social emergency before. I think that's a really excellent way of summing it up. So I'm going to take 2 or 3 questions at a time and read them out, and then you can each take them. So first question we have is from Germain Alacon, and he says, a question for Dr. Zuma. Considering the migrant problematic and the Colombian government offered to guarantee vaccines for Venezuelan migrants, how is Colombia supposed to pay for these vaccines? Is it already stated which ministry or government office is going to pay for them? And if not, who should pay for them? A second question for you is, what do you think could be a better way to improve the health system in Colombia? Is it better to increase investment in preventative health programs or in coverage? And a final question for this round from Camilo Cardenas, who's a PhD student in the Statistics Department at LSE. How would you bring the ideas and findings in academia closer to the actual sphere of policymaking, given the limitations arising from political willingness, short-term planning, and a lack of long-term program design, as Andres pointed out? To your best knowledge, how do academia and policymakers work together and learn from each other? Well, there's a small question to answer. Shall I go to Zuma first?
Yeah, sure. So the first question about who will pay for these vaccines for migrant population, well, that's not the only issue about payment for migrants in terms of health care. So in general, what will happen with these communities is that populations who are not employed will be paid by the general taxes we all contribute in the country under the subsidized regime. And but if these migrants are regularized or get legal status, that will allow them, or a proportion of them, to get actual jobs with social security guarantees. And that means that by doing that, the payment of their health services will come from the contribute regime, which will enable them to contribute to the payment of these healthcare provisions. However, it doesn't mean it's not for the particular issue of vaccination a really, really great challenge. First of all, it needs that the international community, for example, and the COVAX mechanism as well, will be willing to contribute with the extra number of vaccine doses to cover that population. And I think the right way is exactly what the government in this particular situation has done, which is to enable them to get a legal status. And that will mean that they will receive, that the government will enable the government to actually ask for most vaccines for the people, for the residents of the country. And I think is the right way to do it. So shall I continue with the other 2 questions? Okay. So the second one was, what do you think could be a better way to improve the health system in Colombia? Is it better increase investment in preventive health programs or in covering? Well, there are many issues with how the health system is actually working in Colombia, I believe. So, well, this is my perspective. I am not an expert on health systems, so I have to say it's not my area of expertise. But so the system has been really, really good, I think, in terms of providing care for individuals in terms of enable people to access medicines, especially costly treatments, and although it has some issues in terms of sometimes quality and delays, as many other countries, in general, people who have very deadly diseases would be able to access healthcare as well as emergencies, etc. But I think where the situation becomes really complicated is in terms of public health. So the measures that wouldn't be directed to the individual, but to the population in general. And I think the failure in terms of contact tracing, for example, in Colombia, and the failure to integrate different types of systems, who will pay for this, who will pay for that, in terms of vaccinations, in terms of economic support for isolation, etc., etc., that reveals the actual problem in the health system, that is not really interconnected or kind of ready for big challenges in terms of public health rather than individual health. So that's my perspective in that regard. And the final question from Camilo about how to bring the ideas and findings in academia closer to the actual sphere of policy making, given the limitations from political willingness, short-term planning, and lack of a long-term program design. How are the academia and policymakers working together or learning from each other? Well, that's a really difficult question, but my perspective is that as never before, probably, scientists and academics have been closer to politicians. So I, at least from my memory and to the best of my knowledge, I never saw the politicians having as much conversation, as many opportunities to engage with scientists and vice versa, and academics than during this pandemic. And I think it isn't a real easy conversation. So, for example, in the UK, you have an official committee, experts that will inform these different policies. And that mechanism isn't as transparent in Latin America and in Colombia. It isn't, there is no accountability, let's say, for that type of advisors. And so I think it's really hard to get to a point where this becomes the norm and not something that is strange to policy making, decision making process. But I think the pandemic is a great opportunity to think on this, on how we improve this communication between academics and scientists, and how this becomes in some way a formal or a structured mechanism to participate on that decision-making process.
Great, Andres, sorry.
Okay. Okay. No, so on the first question, I think Suma has said it all, and I fully agree. On the second aspect, on be a better way to improve, let's say, health system in Colombia. As I said, I think that there are three main aspects that need to be strengthened. One of them is primary care and reducing fragmentation. The other one is public health, strengthening public health teams, especially local public health teams. And the third one is improving financing. And this is not only putting more money to the system, but also making it more efficient. There are some other aspects as well that are important. Governance, for example, improving information systems is key. And I think there is also a debate that has long-term consequences on human resources, improving the quality of the work of human resources in health. I think it's key. I would say those are 5 key factors that need to be addressed. But as I said, I'm not hopeful that all of them can be addressed at the same time. There was recently a health reform proposed in Congress in July 20 of last year, but it didn't go through. And it didn't go through because it was very ambitious, very open, technically sound, but I think the country is not at the point in which, and this government finishing already is not at the point in which it can, and it has the political leverage to propose such a overhaul to the health system. And on the third one, which is on academia, I think that I agree with Sulma that the academia has been closer to governments as never before, and that's positive. But I'm not hopeful that that is a long-term change. And I say this because when you look at debates on other topics, and I'm bringing again tax reform, retirements and pensions reform, all these kind of things, you don't see that the same alignment as you saw with the pandemic. I think this alignment is siloed in a way, and I think we should take the opportunity to improve that conversation. Governments and academia talk different languages. Governments are in the short-term game, academia is not. And the interests are not only always aligned. I think there are two things that can be done. First of all, from the leadership of universities, I think that the incentives towards scholars need to be also on the side of the practice activities. And I say this from in the school where I work, we're also recognize our practice activities. And I think that should be the case also for other scholars, for other schools, for other departments. It's not only about the papers you write, it's also your contribution, your actual contributions and your actual practice to society that has also value. That is on the level of leadership, and that requires leadership changes at the top of universities. On the other side, I think there's also, I think that there needs to be a change in academics. A lot of them like to be in their ivory tower, and that's great. But I think there is a need for more willingness of scholars to get their hands dirty and care not only about issues that affect everyday people's lives, but also care about implementation. It's not only about having a great idea, it's also about being able to implement it in the field. And I think that on that, and being in the midst between economics and health, I see that a lot in health, but I see that less in economics in other fields. And I think that that's something we should definitely care more about.
That's interesting, Andres, because in the UK, obviously, we have a decision in academia that we have to engage in with policymakers and have impact that then becomes a point of contention for many academics who don't have policy relevant work. So it's interesting to think that that's something you think is more important. Absolutely, it's key. Interesting. I'm going to move on to the next round of questions. So we have German Alacon says, do you think it's a good idea to prioritize isolated communities in Colombia, especially the ones in tropical areas such as the Amazon region, considering these are difficult to reach communities with reduced access to medical care and where there might be a barrier to maintain the vaccine's cold chain? Andres Prieto says, during the pandemic, we talk about the impact on education and the economy, but what have been the effects on the provision of treatment for other conditions such as cancer or organ transport? Are there any statistics with these hidden costs? And the last question for this time is, some could argue that COVID-19 is a health hazard, mostly for the elderly, yet pursued by governments are affecting the whole population. To what extent we as a society value more prolonging expectancy at the expense of education for kids, for instance, or the economy? Quite a controversial question there. To mix it up, I'll go to Andres first.
Sure.
Sorry, Andres, don't feel you have to answer all the questions. If you just want to pick some of them, that's also fine.
Sure. No, I think I'll leave the first question to someone who's more experienced than me on this. I would only say that the virus, I mean, usually these hard to reach communities are hard to reach for governments, but not for the virus. because there are connections. Actually, we have seen this in the Amazonas region. So I think the idea of the government of creating this biological shield by vaccinating people in the Amazon region is a smart one, precisely preventing the potential new variants from Brazil. I haven't seen, responding to Andres, I haven't seen data on these hidden costs, but I think it's really, really important. I know of a couple of groups that are thinking of producing these studies. It's really important because I think we have not seen the size of the burden of disease that we will face once the pandemic is done. Precisely because of the lack of screenings, the lack of treatment. I know anecdotally of physicians who have said we're seeing people more complicated from their usual diseases, but this has not been formally measured. And I know there are a couple of groups trying to do that precisely because this is important. Yes. So in the last, I think that's the. I think that's not a technical. There's no technical response for this. I mean, I could. All of the ones who are here and working in health know that the idea of weighting age, for example, when conducting burden of disease studies, was highly contested, and I think it's an ethical. A decision rather than a technical decision, whether we're going to weight more people based on their age than others. I think what is important here is that we take a decision as a society and we don't allow them ourselves to just go with the default. The default is, let's see next month when the cases go down and we'll open. And then the next month, no, let's see when the positivity is less than 10%. I think we need to take bold decisions now because the long-term consequences of not educating these kids are real. And I mean, it's a difficult decision, but we definitely should at least measure more because we are affecting. I feel that we're affecting more kids because we're not observing them. We're affecting more kids because we believe they're okay at home, and they're not okay. They should be at the school. And instead, we're observing a lot, and we see every day the numbers of people who die from COVID. And that, of course, it's a tragedy, but we are actually not seeing the other side. And until we don't put more attention to the other side, we will not be able to balance the pros and cons of any decision.
Thank you. Zulman.
Great. So about the idea of vaccinating these isolated, and I put that isolated communities, especially in the Amazonas area, I think it's a great decision, and I am really glad the government, because it was actually proposed by the locals of those communities. And the fear from the P1 variant coming from Manaus, and you know that Manaus experienced a second wave larger than the first one that was already really, really dramatic. And the fear that situation would happen again to these communities where access to healthcare ICU units is really, really low. So they were really the proponents of this strategy of getting mass vaccination before the big cities. And I think it was the right one. And it hasn't finished. So Amazonas has achieved pretty much 10% of the population vaccinated. So it's it's still quite a lot to go, but I think it's a very good strategy. Also because these communities are not really isolated, and that's the point. They are at the border with Venezuela, Brazil, Peru, Ecuador. So it's very easy just to move the virus between the borders. And also because these communities are really small, So the benefit from a small amount of vaccines in a big city wouldn't be seen really quickly, whereas for those communities, those little amounts of vaccines will represent a high coverage. So I think from many point of views is the right decision. And second, about cost and the impact on chronic diseases. So I fully agree with Andres. We haven't really seen the consequences of what has been happening with chronic diseases, but I think we need to start I've seen a couple of studies from Chile. They have been really good at least measuring what has been the impact on healthcare demand and provision, and they have found a huge correlation between the number of deaths per million people and the decrease in the proportion of these medical attentions to be provided over the course of the pandemic. So I think sometimes people miss one point, which is some people think that is lockdown what reduces healthcare provision of other services, but they miss the point that is actually the huge amount of COVID patients that take over the personnel and all the capacities that the health system has. So I think are both, but I think the fact that we have given so much space to the spread of the pandemic has been the main factor that has decreased and delayed the attention to these chronic diseases. So everybody, as you and me, we are all busy with COVID, and the same happens with the health system. So I think that the main danger has been really to allow the epidemic to spread as much. And finally, about the school closure. So I am totally I totally agree with the idea. We need. I mean, it's been a year almost from the school closure, and but I think. And I don't agree in this point, particularly with Andres, about that schools were closure because it was thought that children will contribute much more to transmission. I don't think it was, or at least not from many groups in epidemiology in the world, that wasn't the thinking at the beginning. It was the fact that it was really difficult to stop transmission and to control transmission with this virus, that it wasn't really any safe space at all, not just schools, but everything else. And so I think what the system really failed was to adjust the different priorities, to say schools comes first before restaurants, before bars, before everything else. And what has happened is that because the economic point of view in the short terms, in terms of unemployment, et cetera, has come first, all the other sectors have been opened except schools. So I think that, but all the spaces are risk for transmission. So I think what needs to change is actually the priorities. And if we face probably not, and hopefully not, but if we face another wave, that what will need to be closed, hopefully not, as I say, but then bars will be opened, but not the schools. And I think it's about these priorities, what the questions we need to make for our politicians and for us as a society.
Thank you. Okay, so I'm going to turn now as we wrap up. I want to ask you, a final closing question, and something to kind of sum up your thoughts and your, I guess, your hopes and fears. We're now a year into this. What do you think are, what are you hopeful for going forward, and what are you worried about going forward? And I'll give you each a few minutes, and then I think we've come to the end of our questions, so we can bring the session to a close. Any other concluding remarks you'd like to make?
Sulma, please.
Okay. Well, I'm really hopeful that vaccination will be a main source of controlling this pandemic. I'm really grateful that at least we have started, but we need to really speed the rollout process. Is not optimal at the moment. We need to find ways to actually get a mass vaccination program. I think there are some issues right now because vaccine is again, as I mentioned before, depending on the individual health system that we have with all these EPSs and all that, and the fact that it needs to be mass vaccination, that we will be expecting to have huge vaccination centers, but this instead we are having like small little places for delivering vaccine. I think that's a big problem, and I think that is demonstrating right now that the coverage is not going to be achieved if we continue with that strategy. So my main fear is in that regard, that we are not able to change that, and because it's a lot of legal issues behind how we provide healthcare in Colombia are embedded in this strategy. So my fear is that we don't achieve that, and my fear as well is that, of course, pandemic fatigue is all over the place. And if we don't increase vaccination as much and we reduce a lot the measures, as we are seeing it is happening, we'll be experiencing a third wave. And hopefully it wouldn't happen, but my fear is that it could happen in reality.
Can I just jump in and ask one follow-up question on what you said about the vaccine program? Do you think, I mean, other parts of Latin America have used the military to help with vaccination efforts? Do you think that could be a strategy for kind of overriding the issues with the local health system?
Well, there is as well quite a few issues with using the military for healthcare interventions. But I think the infrastructure is really there. The vaccinators are really there. Where I see the problem is in the administrative issues. That if you compare, for example, Chile's vaccination program, it is all the burden to the program is on the offered side, but in Colombia you need to it's from the demand side. So that means that that there are so many barriers still for people to actually get the vaccine. But I think the capacities are there. Is the administrative process how the health system works, unfortunately.
Thank you, Andres.
So no, similarly, my hopes are on vaccination. I really hope that if we got the first two phases, that is all healthcare personnel and all those individuals older than 60, hopefully before the Holy Week or the Day of the Mother, which is known to be a moment of family reunion, similarly to what happened in the second wave. I really hope that wave that we will have, or probably will have, Sulma knows more about that than me, we have less deaths at least, because those people will be protected. The most vulnerable people will be protected. That's my hope. And I also hope we can learn from this and adjust in the future. This shouldn't come as a couple of years that were horrible in our lives, and then we go on with the same that it has been in the past. I think we need to change a lot of things. Part of them is our relationship with the environment. Regarding concerns, I think that I agree with Sulma. We're too focused on the supply, purchase, acquisition, unfairness on the distribution, inequities within countries, but we're less concerned about the demand side: acceptance, willingness to vaccinate, adherence to second dose, inequities within countries. And I think we should focus more on those, because those are the actionable items. On the supply, unfortunately, Latin American countries will have a rough first semester while they get the supplies from Chinese, Russian, and also Western providers. But I think we should focus more on the demand side. And now you're seeing all the discussions around in Argentina, in Peru, in Ecuador around vaccination that have been politicized, and my concern is that that reduces the willingness for people to vaccinate. We have seen this in Israel, younger individuals not willing to get vaccinated, and this, even though if they don't die, these put us at risk of having a strain that these vaccines cannot actually defend us against. So I would say that's my concern. And second, the politicization of the process. In Colombia, we're in a pre-electoral year, and the vaccines, I think, are the favorite item for politicians to use, and that's not good, because we should really, a responsible politician should really keep separated vaccination from their political intentions. I know this is utopia, but it is what a technician would say as me.
Thanks, Andres. I think the term responsible politician is a I know, what's the word? God, my mind's all completely blank. I don't think it exists, does it? Or if it does, it's a unicorn. Thank you both so much. I really enjoyed this evening's session. And Andres and Zulma, thank you so much for your time this evening, or this evening here in London. I'm sure it's earlier where you are, Andres. And really grateful to have your insights on this, on all areas of the health response to COVID, and thinking about longer term strategies and planning for the health sector in Colombia. And thank you to everybody for attending this session. We've had a really great audience, and I'm going to hand over back to Santiago to close.
Thank you very much, Claire. And on behalf of the Colombian Society, thank you, Andres, and thank you, Zulma, for this insightful conversation. I'm already receiving a lot of positive comments, and I think that the conversation held here has been of a very high quality. So thank you very much, and thank you for all of the people that has been connected today. I would finally like to invite you to the other events of the Colombian Symposium that we are gonna host. The next one will be on connectivity, education, and innovation, and it's gonna be next Thursday, 4th of March. So you are all welcome, and again, for all of you, thank you very much for being here. I hope you have a great night.
Thank you, everyone. Stay safe.
Thank you. Bye-bye.
Bye.